patients I've cared for here in this facility who have done wonderfully under their care. They have such attentive staff, really detail-oriented people who are really here to advocate for both patients and their families. I swear, no one put me up to this. I'm really saying they do a fantastic job because I've been in touch with them and I've gotten to work with them as well as some of the people in this wonderful audience. So full disclosures, first of all, I'm fully vaccinated. I took my COVID test this morning, it was negative. In case I lose my voice, I was at the Warriors game last night screaming at the top of my lungs. Hashtag pool party, right? And for a palliative care doctor, you'd never think I could scream that loud or make that many loud boos at the referees. So with that in mind, I'm here as, my name is Dave Tran. I'm the palliative care department lead for Palo Alto Medical Foundation, which covers 5 clinics throughout the Bay Area. We have clinics in San Mateo, Palo Alto. The closest one here is actually Sunnyvale, as well as Fremont and Santa Cruz. So we cover a very broad area. And you might be wondering, like, what is outpatient palliative care? Because it's relatively new in medicine. And what we have found is in our field, by having outpatient offices instead of seeing people just in the hospital, we're actually able to reach a lot more people and sort of swim further upstream before people are really in dire straits and really need our help. So the other thing is that I'd originally planned a presentation on PowerPoint, but that's sort of dry. The weather's really nice. You probably don't really want to be watching me sitting here and staring at a screen the whole time. So I hope you'll forgive me if I'm looking at my slides. So this presentation is called Living Well in Your Golden Years, Palliative Care and Advanced Illness. So just as a primer, what is palliative care? So according to the Center to Advance Palliative Care is a specialized medical care for people living with a serious illness. This type of care is focused on providing relief from symptoms and the stress of the illness. And the goal is to improve quality of life for both the patient and the family. So that's according to the Centers to Advance Palliative Care. And you might be asking, like, what is this guy doing up here? When I talk about improving quality of life, what I'm talking about is working with my entire team of people. So not just myself, I'm one of many people who are there to help patients, including physicians, nurse practitioners, nurses. We have a regular nurse on our team, an RN, as well as a social worker, a chaplain, coordinators, and patient service representatives. So from the time you pick up the phone and hear from our office, you have a whole group of people who are really focused in on helping communicate to your family what's going on, helping your patients figure out, what are the next steps in terms of my illness, and helping come up with plans around the future. And so who do we see? When I say an advanced illness or a serious illness, I'm really talking about the kind of illnesses that really change our lives, that upend our whole world. So the most common thing that we probably see is cases of advanced cancer, breast cancer, thyroid cancer, prostate cancer, colon cancer, all the big C, big scary things. But this is very much our day-to-day work. We also see people with advanced heart disease. So I see some people who have LVADs, which is like a heart-lung machine almost, or kind of like artificial life support in a way. I see a lot of people with heart failure, advanced lung disease like COPD, pulmonary fibrosis. I see a lot of people with renal disease, like end-stage renal disease, especially in the later course of their illness. And I work a lot with neurocognitive illness. So everything from Parkinson's disease to various types of dementia, vascular dementia, Alzheimer's dementia, and actually my personal, my place that has a warm place in my heart is actually working with ALS and movement disorders. I find that to be super, super interesting. And those are often the cases where we're really, really needed. So I do full spectrum palliative care, which means that I really see all organ systems. And I don't really think about, oh, like I'm a heart doctor, I'm a lung doctor, I'm a person doctor. As many of you here, I see nods, that we're really focused on not just treating the illness, but helping support the person behind that. And so when people hear palliative care, right, I have a couple different reactions. My favorite, my personal, and because I think we often see palliative care in sort of the worst time that we're possibly going through, which is usually in the hospital at the end. But palliative care has really changed in the last 10 years. It used to be that palliative care was in the intensive care unit, top floor of the hospital. And then we started moving kind of down the hospital and into regular wards and places where people were really suffering, and we found that we had a lot of value. But what we decided to do as an outpatient palliative care group is really see people in the home. Because a lot of times when you're talking to your doctors, we have a sense of what might be going on. Oftentimes we might have a sense that your illness is changing. Maybe a person, your family member, has been in and out of the hospital recently, and we're starting to have to make some really difficult decisions. And so where do you receive palliative care now? Well, we really meet patients where they are. I see patients at home. If this were 100 years ago, I would be riding around on a horse. I see people at home in places like this: independent living, assisted living, memory care, and also in my actual medical clinic. So if people are mobile and they have the mobility to come in, we like to see them in the office. But actually, I find that I get so much more information from being in someone's home, meeting their family, seeing their dog, seeing what things they might trip over on the way in, seeing how they organize their medications. All this information comes from being really present with patients and being where patients are. Palliative care often takes place in the hospital after a serious event. And unfortunately, we're not actually going to the hospital at this point, but that's partly because we have palliative care teams in the hospital already. So we're trying to go as far upstream as we can to try to catch people where they need us. So I kind of think about what I do in a couple buckets. The first is what we call symptom relief. So really looking at, what kind of symptoms are you having from your illness? Maybe it's pain, right? Especially in dealing with advanced cancer and you're dealing with bone pain, metastases, or just side effects from your treatment. So we have a lot of expertise in dealing with advanced pain. We see a lot of people with nausea, vomiting, constipation, a lot of GI symptoms, right? Because you're getting really, really difficult treatments that often cause a lot of symptoms. He's telling me to keep going. And it's kind of funny because a lot of my patients, when I first meet them, I know that the first thing that I could probably do for them is make them comfortable. And so I'll ask them a lot about their symptoms. And one of the first things I say to people is, I apologize ahead of time. I'm going to ask you a lot about your bowel movements. Because a part of aging, unfortunately, is losing mobility. And sometimes it causes other issues, right? Slow gut motility, dehydration, all these things. And so I have a really big role with my patients in managing those things. Sometimes we also manage behavioral disorders, but we're not psychiatrists. So really serious behavioral disorders, I often work with other psychiatrists and other doctors to help figure out the best way to manage somebody. When it comes to memory disorders, again, I work with neurologists. We work with other specialists and your doctors. One to figure out, what's next? What's important about this illness that I should know? What are your treatment options? And what are the side effects that we expect from these treatment options? And then what I hear from patients actually a lot of times is, what's coming? What's going to happen now that I've been diagnosed with this illness? And so a lot of times I'm really communicating this information because I kind of think of it like a bomb going off. If you've ever been in a doctor's office and you receive bad news, you kind of hear the bad news and everything after that is it's just sort of like an explosion, right? Your thoughts are racing. And so a lot of times I go back and I help clarify some of that information. I really try to do this at the level in which patients communicate. Sometimes it's in other languages, like Vietnamese or Spanish. Sometimes it's using a translator if necessary. The second bucket I think of is really, I call it sort of planning for the future. And part of planning for the future, which is actually where a lot of people in this audience are involved. I thought I spotted a few people in the legal profession. But planning for the future really means, well, asking questions like, well, if you're having an emergency and you're not able to make decisions for yourself, who would you want to make those decisions for you? Just as importantly, who would you not want to make those decisions for you? So a lot of that is planning for the future and thinking about, well, as your illness changes, what's important to you? Some people think palliative care is a really sad profession. I actually have a lot of joy in this work because I learned so much about people's preferences and what they find important. So my favorite questions are, what brings you joy and meaning in life? What's important to you? What keeps you going from day to day? It could be as profound as waiting to get my Nobel Prize in the sciences. It could be as simple as, I like whiskey and French fries, and that's what I do every day, and you can't take that away from me, and that's fine. But each of those questions gives me a bit of information in helping me understand, okay, as we adjust your treatments, as you're going through this sort of medical illness, how can your doctors better support you in that? And how can I do a better job advocating for you and making sure that we're not getting away with those goals? Part of planning for the future really is advanced care planning, which if you're in the legal profession or you do any sort of estate planning, what I really try to do is create a framework or a safety net to where if you're in dire straits, our patients know who they can lean on. So that information is in the medical record because it's less helpful if it's in a drawer somewhere and you're having an emergency. And figure out sort of in general terms, well, if I was really sick, what would I want things to look like? Where would I want to be? Who would I want to have with me? And so that kind of fits into the bucket of advanced care planning. And a lot of times it's really me communicating this with other doctors, helping them understand the person on the exam table a little bit better, but also making sure the right people are included in the conversations that we're having. Because a lot of times we see people that their family members aren't nearby, and we're trying to figure out who do we talk to. The last thing is actually something called a PULSE form, which, if you're not familiar with it, stands for a physician order for life-sustaining treatment. There's a lot of euphemisms for this form, but as a doctor, actually, I have a role in signing these forms, helping people figure out what does all this medical terminology mean? Because if you look at the PULSE form, it's this bright pink piece of paper, and it's full of kind of unusual words, and it's actually just sheer medical jargon. And the reason for that is it's direct communication to medical professionals, EMTs, emergency room doctors, of precisely what medical interventions you would want, and just as importantly, what medical interventions you would not want. And a lot of times I'm communicating, well, what does that mean, right? COVID completely changed this conversation in the strangest ways. Because I used to have to explain to people what it meant to be intubated, what it meant to be on a breathing machine. Now we all have this sort of unfortunate understanding of what that is. And what I'm finding in my work now is people have very strong ideas of what they would not want in that situation, as well as what they would be comfortable with. And so again, all this is getting this in place so that our patients, when they come to this point in their life, if there's an emergency, you already know what the next step is. And what I often say to families is, it's uncomfortable having that conversation with your loved one. It's even harder having that conversation in a hospital at their bedside. Or, as we learned during the pandemic, through a screen or on the other side of a fence. So I've been there to facilitate this conversation with a lot of families and loved ones right here in this facility. And then the third and probably the most important thing that I do for a lot of my patients is determine what we call goals of care. Now, if you're in the hospital, this means something completely different in some ways. But when I talk about a goal of care, I think about, first, how do I reconcile your personal values, what you find important, the sources of joy, meaning in life, with the medical reality and the options that you have in front of you. Doctors are people too, but they sort of think on that scale, right? They're thinking about your heart, they're thinking about your lungs, but they might not pull the pieces together. So a lot of what I do is trying to understand you as a person, working with your family members, working with loved ones, to help figure out, okay, well, how do we reconcile these two things? Because that really tells us what our goal is. And usually I'm checking in and going, what's your understanding of your illness? What's your understanding of your family member's illness? And how can we support you? And one question I often ask is, given your medical condition, your personal values, your options, what do you hope for from your treatment? Because a lot of people have this misconception that palliative care is about taking hope away from people, when, as I've learned, it really couldn't be any further from the truth. It's about trying to identify those sources of hope as a strength to help us reach our goal. I have patients who have wildly different values. Some people say, well, my goal in life, even though I'm very sick, might be, I love to run. If I can't run it, I've had Olympians I've even take care of who said, if I can't be running tomorrow, I don't want the treatment. Which some people would go, how would you do that? But that's what that person finds in life. At the same time, I've also had people say, well, I find joy in just sitting with my cat reading a book. And as long as I can do that, I'm happy. I said, perfect. Great. I'm putting that in your chart. And so a lot of this kind of sounds sort of soft in terms of the science, the medical profession. But I promise you a big part of this is really improving quality of life. Again, your doctors weigh pieces of information like what is this person's creatinine, what does their sodium look like, what do their labs look like, what are the conditions they have. I'm using each of these pieces of information as I talk to patients to understand them. And when I say improving quality of life, it means helping them have more time at home, if desired. If people are going back and forth from the hospital to facilities, many of us have seen this before. It's sort of home, hospital, nursing home, hospital, nursing home, hospital, nursing home, right? And then eventually, hopefully back home, usually with home health. And that quality of life sometimes is more time with family, if desired, right? Because that time at home is time that you're with your loved ones, where you have control over your environment, versus being in places where you might not have control over who's around you, who comes barging into your room at 5 in the morning to draw blood, who comes knocking on your door to feed you hospital food, and then weighing your tray to see how much food is on the tray. So a lot of that time is really spent focusing on that quality of life, which honestly for most people usually means being at home or in facilities that are familiar and home-like for them, wherever that home is. And a lot of times what I find, especially here in the US, is that the goal is really avoiding institutionalization, which I think for a lot of our elders is one of the sort of deeper, darker things that we fear as we get to that point in our lives. Most of us don't really want to be in a facility. So my job and what I love about it is I get to help people avoid that. And your doctors see the path ahead, but they're trying to figure out how they can steer that in the right direction. And my skill set is around communicating that so that we can understand what the next steps are. And really, my goal is to allow patients to spend more time doing the things they love, wherever they want to be. From a more scientific or more of a health systems-based sort of perspective, people often ask me, what does quality of life really look like? How do we measure that? Well, a lot of this is what we call goal-directed care, meaning that if you're going to go through a serious number of treatments, right? We're talking 20 radiation treatments, we're talking round after round of chemotherapy, we're talking lifelong medications, things that are really, really serious. My question is, are you really getting what you want out of your treatment? Because I can take your ice cream away if you have uncontrolled diabetes, but that doesn't bring quality of life. Right? The scientific thing to do is measure the numbers and try and you start attacking the numbers. But my favorite thing to do is give people Slurpees and ice cream when they feel like it. I often drive other doctors a little crazy for that reason. But I'll share a story. Is one of my patients, and who had advanced cancer, and she's still my patient. She was a little distrustful of me, so we got on video, and she goes, "You're palliative care. You're going to stop my treatment, aren't you?" I said, "No, I'm just here to see how I can help you feel better." And she had been deprived of the foods that she loved because she had a feeding tube in place, and was really, really sad about this. And I said, "Hey, look, I'm not going to change any of your treatments, but here's what I'll tell you to do. Don't tell the other doctors I did this. I want you to go to 7-Eleven, get a Slurpee. You don't have to swallow it. It's fine. Just trust me on this one. It's going to be the best thing you've ever done." And she goes, "Oh, that sounds crazy. That's ridiculous." And I said, "Okay, well, I'll see you in 2 weeks." And I saw her again 2 weeks later, and her tone completely changed. It was the funniest thing. She goes, "Dr. Tran, what you did for me was totally different from what I've had any other doctor tell me to do." And I said, "What is that?" She's like, "You told me to drink a Slurpee." I haven't had anything to drink in months. That was the most glorious thing that's ever entered my mouth. So I get to do fun things like that. And a lot of times, it's really centered around quality of life. Because I could go chasing after the numbers, but it might not make a big difference. A big part of this is avoiding unnecessary or unwanted procedures. And especially for people dealing with a neurocognitive illness, if they lose the capacity to tell us exactly what they want, when they are still able to tell us, it's really nice to have that written down somewhere. Sometimes in advanced directives, oftentimes as part of a post. But some people are really clear with me and saying, "Hey, if this happens to me, do not put a feeding tube in." Because one important thing I've learned is that feeding tubes, even though they sustain life, which is what hospitals and doctors are really good at, they haven't really been shown to improve quality of life. And when I talk to my patients about this, and when I talk to other doctors or when I teach residents about this, one of the first things I say is if you're going to do this and you're going to talk to someone about this, understand that this is a bridge, and that bridge has to go somewhere. And so avoiding unnecessary or unwanted procedures, that's a big part of this conversation. Avoiding unwanted hospitalizations, reducing symptoms, caregiver burden, stress. So when I work with my team, our social worker, our chaplain, we're really looking at patients as whole people. Meaning, what are your loved ones going through? If you've ever been a family member for someone who is sick, if you've ever been a caregiver, we all have these really lonely moments that sort of drive us probably to this place to do the kind of care that we do. And our social workers are there to provide emotional support for people. We often connect people to really important resources like IHSS. We often help people find caregivers. We help people figure out where they need to be if that place can't be home. And from a spiritual perspective, what makes this really unique is our site in Sunnyvale is one of 2 sites that has a chaplaincy program. So we have 2 chaplains, one in Santa Cruz, one in Sunnyvale. And while this is actually very fundamental to palliative care, it's sort of unique to our setting because you don't find a lot of chaplains in the outpatient setting. Unless you're in a hospice, I can see Tran nodding at me over there. But there are many different types of suffering. So pain is one of them, but what about emotional suffering? And for people who are at that point in their lives, there might be a huge part of this that's what we consider spiritual suffering or existential suffering, wondering, why is this happening to me? Why? I've been a good person, right? And so our chaplain is a wonderful part of this. And what we've really found that's super interesting is that when you address existential and psychosocial pain, physical pain gets better. And when we control symptoms and reduce stress, we actually have better medical outcomes. People can be on treatment for longer, get better outcomes, they're more resilient because we've been focusing on sources of hope, sources of strength, sources of resilience. And to some extent, I hear this a lot. It's not my favorite thing to talk about, but it does actually significantly reduce the cost of care at the end of life. And one conversation I've been having with myself and very loudly with other people is that medical care and caregiving, especially for seniors in this country, is extraordinarily expensive. I see so many nods, right? It can be on the scale of thousands of dollars a month for a couple hours a week. It can be, as I've recently seen, $10,000 to $20,000 a month for 24-hour caregiving, even with VA benefits and support from others. Most of us didn't really plan for this, unless you're like one of my patients who got really lucky and had the world's best long-term care policy I've ever seen that actually had no limits on it. But those are pretty rare and far between. And so that reduction in cost of care for some people actually in their families, that's a really important family value to them, is they worry about how their illness will affect their family. So sometimes that's not my primary goal, but what I'm trying to help understand is how can we make this easier for you, right? Because the worst thing we can do to someone who's sick in this country, and this happens every day, is they're sitting there looking at their bills. And I've been to so many homes where I see stacks of paper stacked up, right? Trevor Noah did a really great skit on this recently, and he goes, this is the only country where you get like an imaginary fake bill, your explanation of benefits that tells you how much your care was supposed to cost, and then you actually get your real bill later on. So a lot of this really is by reducing those unnecessary procedures, unwanted hospitalizations. It doesn't make sense to put this on our patients that they have to get this unwanted care and then their family has to take care of it later on. And so a lot of this really is trying to see how many ways I can reduce the stress in their life, whether it's financial, emotional, spiritual, or just plain physical. That's the easy part. Our social workers, chaplains, some of our legal professionals, everyone involved in this process has a huge role in this. And I see so many people here from home health, hospice care, and different agencies. You guys are all part of this work. We were featured recently in Palo Alto Online in an article called "As the Aging Population Rises, More People Turn to Hospice for Enrichment and Comfort." Again, that's on Palo Alto Online. And what I loved about this article, they interviewed me, of course, but is they said hospice brings humanity back to the dying experience. I would argue for palliative care, that should really be present through all phases of your care. Whether you're well or you're not doing so well. Palliative care really has a role throughout that continuum, but especially in those final years or months. So a few people might be wondering, well, what's the difference between palliative care and hospice care? These are really separate services. People don't realize that. And the difference is that with palliative care, patients are still on disease-modifying treatment, meaning if you have cancer or you have another serious illness, I'm here to support you while you get your treatment. You can continue to do that. And with the right interventions, you might even be able to live longer and with a better quality of life during that time. A lot of times I see people when the prognosis or the time span that people have is sort of uncertain. They're sort of at a juncture in their care trying to figure out, again, what are the next steps? What are the trade-offs of these next steps? What does that look like? And again, my services are actually paid for through just regular insurance. So with myself, I'm under the Sutter Network. It's all approved for by insurance. You shouldn't see a bill for my services at all. We understand how important this work is. Hospice care, by comparison, instead of being disease modifying, it's what we consider comfort directed treatment. And people kind of go, well, what's the difference? Well, the difference too is that it's not really about giving up your treatment or giving up anything, really. It's actually about gaining a lot of freedom by leaning into that comfort. And when I look at hospice care, I think about the goal as really fully focused on that quality of life, really focusing on comfort. Hospice care, to qualify for that, usually means that you have a prognosis or a time span of less than 6 months. I don't often get people whistling at me, so it's kind of nice. So again, hospice care is usually for people with a prognosis less than 6 months and should be fully paid for by Medicare. Most of the hospices, and we work with many hospices throughout the Bay Area, should all be paid for by Medicare and should be 100% free. There are for-profit hospices, and they're allowed to sort of bend the rules because they're not beholden to the federal government. What I usually advise people on are ways of comparing hospice agencies, working together. There's a Medicare Hospice Compare website that I like to use because people often go, well, I have all these options. And a lot of times I'm making suggestions to patients based on the quality of care that I've experienced. And honestly, I don't send people to places where I wouldn't want to get care or that I wouldn't want my family members to get care. And so hospice care, again, comfort-focused treatment, really towards the last 6 months of life. And palliative care is when you're still getting disease-modifying treatment, the prognosis is uncertain. And really, people are in a situation where they really need a lot of emotional and physical support to get through their treatments. So fun fact, people sometimes ask me if you could put anything on a billboard about palliative care, what would you say? And I say, patients with high quality hospice and palliative care often live longer than we expect. They live longer because we've removed all the sources of stress. We've removed a lot of the physical symptoms that are preventing them from getting good treatment. And they live with a better quality of life. So I think when I talk to patients, I understand the hesitation because I've been there. But when I talk to people about the work we do, and I know this from the hospice folks as well, letting people know that, no, palliative care is just here to support you. They're here to support patients. We're really here to help people. And we're not here to force you to do anything. Good quality palliative care really helps you identify what those goals are so we can move forward and reach them through your care. So some of you might be wondering, maybe you have a family member, maybe there's patients here, maybe you know somebody who would benefit from palliative care. You might be wondering how to receive services. The first thing is if you have a primary care doctor, or if your loved one has a primary care doctor, reach out to them to see if your health system, wherever you're insured or wherever you receive your care, has palliative care. We're really fortunate in the Bay Area. We have 2 major fellowship programs that crank out new graduates every year. And because of that, we have a lot of palliative care in this area, which is great. But first step would be talk to your primary care doctor. Second is if your primary care doctor doesn't know what palliative care is, you can call your insurance company. Insurers love us as well, and part of the reason for that is they look at more so the cost of care aspect of it, but they're happy to connect with services. A lot of insurers also have their own palliative care service. The only thing I would be really cautious of is if you do get a call from an insurer saying, hey, we're palliative care, we're here to help you. Usually the first question I recommend asking is, do you have doctors and nurse practitioners as part of your service? Do you have people who can control my symptoms? Because they might be at a different angle. So I just want to be mindful of the quality of care that people are receiving if they make that statement. But again, your insurance company should have a network of palliative care providers, if not your primary care doctor. And then the other thing, actually, a lot of hospices have home-based palliative care programs that are affiliated with their agency. So sometimes if you Google them, you can actually find them. And I would actually reach out to them directly. Most hospices are happy to get calls from patients and family members who might be searching for services. So if you're looking for this, there's a number of hospices that have palliative care and home-based palliative care as part of their services. I think we have a little bit of time for questions. It's about 5:12. Thank you guys for listening so intently. Any questions?
Hang on a sec. We're going to do a quick thing. Thank you very much, Dr. Tran. We are going to have questions. Don't go anywhere. So formulate your questions. Those who are on live stream, this is a good time to type the questions into chat. And Gary, come on up. Gary has a few words to share, and then we'll get back to Q&A.
Thank you, Wesley, and thank you, Dr. Tran. Very interesting information. I appreciate that. So one thing I did want to mention is that we have a project coming up that will be breaking ground in Saratoga in somewhere in September, October. They're off Highway 85 and Saratoga Avenue in Cox, behind the pumpkin patch, if you're familiar with that area. So there's about 10 acres of land, and we purchased 1 acre.
We are going to have
so
questions.
Building
Don't go anywhere.
Property, the 79 unit memory care community,
those who are
which will
on
be
live stream,
presented to our community in about 2024. So keep your eyes out.
Gary, come on up.
The plan is to have 3 levels of care.
We'll get back
really
to
low
Q&A.
acuity, medium acuity, high acuity care, where people can live. Thank you, Dr. Tran. Through the rest of their lives, as they progress through dementia. So one thing I did want to mention is that we can take care of them. We have our we're very excited for that project. You'll be hearing breaking ground in Saratoga months and years to come. Somewhere in and then we'll have a grand opening, a ribbon cutting coming Highway 85 and Saratoga Avenue in Cox. So look out for that. Thank you so much. Familiar with that area. So there's about 10 acres of land, and we purchased 1 acre.
We're going to have questions. Don't go anywhere.
Property.
Okay.
79
Let's formulate
memory
your
care
question.
community,
Those who are
which will
on
be
live stream,
presented to our community in about 2024. So keep your eyes out.
Gary, come on up.
The plan is to have 3 levels of care.
We'll get back
really
to
low
Q&A.
acuity, medium acuity, high acuity care, where people can live. Thank you, Dr. Tran. Through the rest of their lives, as they progress through dementia. So one thing I did want to mention is that we can take care of them. We have our we're very excited for that project. You'll be hearing working around in Saratoga months and years to come. Somewhere in and then we'll have a grand opening, a ribbon cutting coming Highway 85 and Saratoga Avenue in Cox. So look out for that. Thank you so much. Familiar with that area. So there's about 10 acres of land, and we purchased 1 acre.
We're going to have questions. Don't go anywhere.
Property.
Let's
79
formulate your question. Those who are
which will
on
be
live stream, this is
presented to our community in about 2024. So keep your eyes out.
Gary, come on up.
The plan is to have 3 levels of care.
We'll get back
really
to
low
Q&A.
acuity, medium acuity, high acuity care, where people can live. Thank you, Dr. Tran. Through the rest of their lives, as they progress through dementia. So one thing I did want to mention is that we can take care of them. We have our we're very excited for that project. You'll be hearing working around in Saratoga months and years to come. Somewhere in and then we'll have a grand opening, a ribbon cutting coming Highway 85 and Saratoga Avenue in Cox. So look out for that. Thank you so much. Area. So there's about 10 acres of land, and we just 1 acre.
We're going to have questions. Don't go anywhere.
Let's
formulate your question. Those who are
which will be presented to our community in about 2024. So keep your eyes
The
out.
question was, does Medicare HMO and other health plans cover palliative care? Most health plans should. I will say
Gary,
that
come on up.
Gary,
We'll get back to Q&A.
doctors and trying to build teams. How they do that is a little shaky. And so when I look at other palliative care programs, I try to figure out who's on the team.
Acuity, medium acuity, high acuity care, where people can live.
Sometimes
Dr. Tran, through the rest of their lives, as they progress through dementia. So one thing I did want to mention is that we can take care of them. We have our we're very excited for that project. You'll be hearing working around in Saratoga months and years to come. Somewhere in and then we'll have a grand opening, a ribbon cutting coming Highway 85 and Saratoga Avenue in Cox. So look out for that area. So there's about 10 acres of land.
There are other home-based palliative care programs.
Just 1 acre.
There are.
anywhere.
Go
ahead, let's formulate your questions. Those who are
which will be presented to our community in about 2024.
The question was, does Medicare, HMO, and other health plans cover palliative care? Mostly as a bridge into hospice care, but I will say
Jerry,
that
come on up.
Jerry,
Jerry,
you have the levels of care.
we'll get back to you.
medicine is extraordinarily high. If you think about that, right? How they do that is a little shaky. Primary care, and so when I look at other palliative care programs, I try to figure out who's on the team.
Acuity, medium acuity, high acuity care where people can live Dr. Tran through the rest of their lives as they progress through dementia. But one thing I did want to mention is that we can take care of them. We have our very excited about project that we've been working around in Saratoga months and years to come. And then we're doing opening, a ribbon cutting coming up in 5 and Saratoga Avenue at
actually trying to build palliative care programs throughout the Bay Area. So the most recent one was in
they're looking
to land. There are other home-based palliative care area. There are. So unfortunately, we can't get to mostly as a bridge into hospice care. But I will say
Jerry, come on up. Jerry, you have the share, and then we'll get back to you.
Medicine is extraordinarily high. If you think about that, right? How they do that is a little shaky. Primary care, and so when I look at other palliative care programs, I try to figure out who's on the team. So the question was,
Dr. Tran through the rest of their lives as they progress through dementia. But one thing I did want to mention is that we can take care of them. We have our very excited about project that we've been working around in Saratoga months and years to come. And then we're doing opening, a ribbon cutting coming up in 5 and Saratoga Avenue at
lots about how we treat care programs throughout the Bay Area. And honestly, the core of medicine was really looking at there are other home-based palliative care area. There are. We can't get to
which will be presented to our community in about 2024.
Everyone is most health plans should. But I was the first
one. Jerry, come on up. Jerry, you have the share, and we'll get back to you.
Biologically speaking, how they do that is a little shaky. And so instead of like look at other palliative programs, I try to figure out who's on the team and helping her understand the question was,
I wasn't going to Dr. Tran through the rest of their lives as they progress through dementia. But one thing I did want to mention is that we can take care of them. We have our very excited about project that we've been working around in Saratoga months and years to come. And then we're doing opening, a ribbon cutting coming up in 5 and Saratoga Avenue at
lots about how we treat care programs, helping them understand. And honestly, the core of medicine was really looking at there are other home-based palliative care area. There everyone is kind of should. But I was the first one.
Jerry, come on up. Jerry, you have the share, and we'll get back to you.
Biologically speaking, how they do that is a little shaky. And so instead of like look at other palliative programs, I try to figure out who's on the team and helping her understand the question was,
I wasn't going to Dr. Tran through the rest of their lives as they progress through dementia. But one thing I did want to mention is that we can take care of them. We have our very excited about project that we've been working around in Saratoga months and years to come. And then we're doing opening, a ribbon cutting coming up in 5 and Saratoga Avenue at
lots about how we treat care programs. Helping them honestly, palliative care looks like from really issues. One of the important things is that we call my clinic to schedule actually we call patients at. But I was the first time.
Gary, come on up. Gary, if you would share, and we'll get back to you.
Because again, biologically speaking, how they do that is what you're going through. So instead of like what I hear in other patients that have programs who are I try to figure out that was really helping to understand the question was I was sure if I started
Dr. Tran, our lives as residential. But one thing I do want to mention is that the question we have are very excited about the project. We'll be working around in those months and years to come. And then we're opening a repeat and Central Avenue at
how we try to doing so. And the question is not as important as like from really what is one of the important things is that we call my clinic to schedule actually we call patients at. But I was the first time.
Gary, come on up. Gary, if you would share, and we'll get back to you.
Because in my mind, because again, biologically, how they do that is what you're going through. So instead of like what I hear in other patients that have programs, and then after I figure out that was really helping to understand the question was I was sure if I started
Dr. Tran, our lives as residential. But one thing I do want to mention is that the question we have are very excited about the project. We'll be working around in those months and years to come. And then we're opening a repeat and Central Avenue at
sometimes there's, I mean, part of it is just the question is not as important as like from really what is one of the important things is that we call my clinic to schedule actually we call patients at. But I was the first time.
Gary, come on up. Gary, if you would share, and we'll get back to you.
Because in my mind, because again, biologically, how they do that is what you're going through. So instead of like what I hear in other patients that have programs, and then after I figure out that was really helping to understand the question was I was sure if I started
Dr. Tran, our lives as residential. But one thing I do want to mention is that the question we have are very excited about the project. We'll be working around in those months and years to come. And then we're opening a repeat and Central Avenue at
sometimes there's, I mean, part of it is just the question is not as important as like from really what is one of the important things is that we call my clinic to schedule actually we call patients at. But I was the first time.
Gary, come on up. Gary, if you would share, and we'll get back to you.
Because in my mind, because again, biologically, how they do that is what you're going through. So instead of like what I hear in other patients that have programs, and then after I figure out that was really helping to understand the question was I was sure if I started
Dr. Tran, our lives as residential. But one thing I do want to mention is that the question we have are very excited about the project. We'll be working around in those months and years to come. And then we're opening a repeat and Central Avenue at
sometimes there's, I mean, part of it is just the question is not as important as like from really what is sorry, I avoid calling people patients because it just kind of tickles this part of my brain. But if I'm seeing somebody and they have a doula involved already, I'm happy to communicate with them. Now, as a department chair and like a doctor, I have to think about this sort of from a medical legal standpoint. And the reason why I mentioned that is that my framework for this is that if a patient wants somebody there and they've given us authorization from a privacy standpoint to communicate with that person, great, that's a source of support. And where I found end-of-life doulas to be very, 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 very helpful is in cases where people are unrepresented, meaning they don't have family members. They don't have people around them who can understand, but they now have this source of support that they can actually hire out. I found end-of-life doulas to be really helpful, actually, and a big interest working with the California End-of-Life Option Act, which is an area of my expertise, because there's a lot of conflict within palliative care when it comes to medical aid and dying. There's a lot of terms for this, and I can talk more about this. I'm happy to answer questions on that. One thing that comes to mind thinking about this question is that there's some programs out there, they're typically volunteer programs in hospitals, and I've seen them, and there's volunteers in this concept called Nobody Dies Alone. Have you heard of that? That's for patients who are unrepresented. Some hospitals will call a volunteer in to sit by that person's bedside at the end. It's extraordinary work. But there are people in the community who really don't have someone there with them. And I think doulas have a really great source of support. Now, the hard part about this is that they don't have the same sort of medical training and scientific background, so they're kind of considered a lay profession in that way. Unfortunately, there is sometimes butting heads, right, with spiritual care professionals, meaning licensed chaplains who have gone through extensive training, as well as social workers who have a really important role in very sort of more academic and formalized role. My goal in working with doulas, really anybody involved in that person's care, is to get us all on the same page to make sure that we're moving forward in the same direction for that person. If that makes sense to me.
The hospitals that sent this program.
It was someone was asking about the program I just mentioned. It's just a concept. It's called Nobody Dies Alone. Yeah. And so these are typically volunteers, and they're sort of organized on a community level in sort of various places, usually in hospitals, to make sure that people aren't alone at the end of life. Yeah.
Great.
And I do actually want to shout out staff at facilities like this one are often those people, right, caring for the people who are very, very sick. So I just want to shout that out. Any other questions?
I got one more.
I love the way that you ask the question. Most doctors don't start with that. And what are some things you found people say? Are there some themes you've heard from people?
So the question was, I asked the question to my patients or to people I'm caring for, what is meaningful for you or what brings you joy? And what are some of the more interesting answers? This is like my favorite thing in my work, actually, is people say the strangest things, but they also say really meaningful things, right? Because you're asking them what is most important to them. I would say the themes, the most common thing, and it's so interesting to me, is time with family and friends. Easily the most common thing. I've had people express regrets to me, but I have never, ever, and this has changed my life and my entire view of this, I have never, ever had a person go, I wish I bought that Rolex. Right? Because no matter how wealthy you are or how not wealthy you are, the thing that we all have in common is the one thing we can't control is time. Right? And so it's usually time with family, time with friends. Nature is another really important one. I don't often hear, man, I wish I moved into that nice house. Maybe in the Bay Area, but I don't often hear like, you know, I wanted more time indoors. Like it's often, I wish I spent more time hiking or on the beach. In fact, one of my patients, her biggest wish, she was very, very sick, and we were trying to figure out how to make this work. It was nothing short of a miracle. And I won't take credit for this because I had very little to do with it, but she really wanted to go back to Hawaii. She wanted to dip her toes in the sand. And so we got wheelchairs, we hired a bunch of people, they literally carried her and took her with her husband all the way to Oahu. And they renewed their vows on the beach, and they carried her in her wheelchair into the sand. It was the most beautiful thing. Yeah. So yeah, I would say time with family and friends, time in nature, and really relationships. Yeah.
Okay, thank you very much.
You're very welcome.
Thank you very much, Dr. Tran. Yeah, feel free to stay behind. There's going to be food and drinks if you'd like to. Okay, so this is the kind of networking